So I work for a USA program, and my job was to make sure that the quality of the program was what was stated. I was the senior technical advisor. Um, and so I did that. But before I did that, I'm like, oh my gosh, I've never been to Indonesia. I never worked with Asians, actually. Where is Indonesia? All these things. And again, I wanted to say that even with Ebola, although I didn't emphasize it, it's so cool to just live somewhere else and just kind of feel it. Like, here is the end of Ramadan. I actually not Muslim, but I practiced Ramadan in respect for my colleagues. And this is the end of it, where you wish someone a sort of clean spirit and brain. And so I just love the rituals and the my colleagues, my friends, my people, my community that I was with. You can see it's quite comfortable. Um, and then of course the food is pretty awesome. Um, Not to bag on Liberian food, but Liberian food it doesn't kind of compare. So my job was to go and to make sure that the program was uh, doing the right thing. And of course, they were pushing what you see, or in any public health school, they're pushing neonatal resuscitation, treating of preeclampsia for pregnant mothers who have high blood pressure, prevention of postpartum hemorrhage, treat kangaroo mother care, and encouraging of breastfeeding for sick babies. And so what Paul Farmer had taught me is that don't go for the tour, just go work in the hospital, like sit there at night on a weekend, and you kind of see very quickly what's going to happen. And I realized, and I'll just use an example, there are many different types of examples, but for babies, um, that the babies were not getting fed. They weren't getting fed for a couple of reasons. These are all hospitals in Indonesia, basically. They're not getting fed, because they're too sick to be fed. And then B, sometimes the mothers, they don't breastfeed well, immediately after birth because they're sick, etc. And so the babies get an IV put in them and the liquid just flows. And this was an obvious reason why the neonatal mortality rate was so high. And you could see that, in addition to, if you looked at the scale, that it doesn't work, right? Here it says it's low, right? But then when you looked at the chart, you don't have to speak Indonesian, but here you see Barapadan, right? Which is, oh, by the way, learn languages of the countries that you live in is awesome. Means your weight. And I know that babies gain 15 to 30 grams a day, but these babies were at 1200, 1300, and 1200 again. So I knew that there was no weight being done. So we came up with an intervention. It's kind of easy, so easy, right? You don't even have to speak Indonesian for this, is that the babies would be weighed, right? So let's say it's 2.4 kilograms, a little bit over 5 pounds. And then the baby would then have to be fed 45 cc's every 3 hours of formula, right? So these are babies that are sick, can't breastfeed, right? Now they can't suck, then you put a tube down their throat, but it can be easily done. Here's another example. Oh, you are 2.5 kilograms. So then you will give 47 cc's. We did many studies that simply to feed the babies, you would decrease mortality over 50%. It didn't need anything else. But it turns out there were no scales. Like, who has a scale? And it turns out the scales that we use in the United States are like $3,000. So I settled on a vegetable scale, $12. Everyone got a vegetable scale. And then we ripped off the top part of their old scale. And that's what we used to weigh the babies, because we needed to the nearest gram. And then, of course, we had to do some teaching. But you can see it was kind of easy, right? You just kind of look at the piece of paper, blah, blah. Eventually, we came up with the equivalent of checklists for every maternal and neonatal emergency that there was. And here was the booklet. And of course, we converted to Indonesian. And I felt so happy. How do you think my organization felt? Basically, I was fired. I was fired initiating this intervention. I've only been fired twice, but it was quite traumatic. But it was my fault. I was entrusted to come in as a USAID representative or sorry, to support a USAID grant that had already decided the intervention a long time ago. I was maybe to tweak it, but I was not to fundamentally upturn. And I had thought to myself, why didn't I pay attention to that leadership class that I took in public health that talks about, like, if you're going to make change, you better do it with colleagues and with company. You better be a known entity before you decide to deal with the politics of making people angry. Don't always think that you're the smartest person in the room. So after giving myself like a month to be seriously depressed, it helped that I went to try to fight Ebola. My wife was still in Indonesia. I said, I still got to do something. I still believe the idea. Now, the way I did it was totally wrong, but there still has to be a way forward. So what I did is I started with this idea of behavior again. And I said, the problem in Indonesia, from my experience and through study, was that the health professionals, they don't follow protocols. Just like the Liberians, or just like you want someone to doff correctly, don't you want your healthcare provider, whether it's a doctor, a nurse, or a CHW, a community health worker, to follow an evidence-based protocol? But my experience was that 70% of the time, and just so you don't get too arrogant, in this country, only 40% of the time, 70% of the time, the doctors did not follow the protocols. And the differences between here and there is that you die. So I systems mapped essentially I systems mapped this problem, and it's very easy. You say, okay, let me see, you start with a problem. I just reversed this to a solution. You start with a solution. You say, okay, health professionals routinely follow protocols. Okay, idealize that. How would they do that? And you can see, oh, they have access to those protocols, right? Oh, they have enough prerequisite training. Oh, they have all the tools necessary. And then how would you have all the tools necessary? Oh, you would just keep on going that. And that is systems mapping. It's beyond, and this is what you learn though, is that's how you come up with the logical framework for interventions, with the very bottom pieces being activities. And then you think to yourself, going through this behavior change, what could I do that was coherent to make sure that those activities happen? And so, of course, it decided to involve technology. But I wanted to make sure that it wasn't stupid technology, like the technology that I was seeing left and right, whether it be in sub-Saharan Africa or Southeast Asia, where people would this would be very typical, like text messaging to poor people, rich people text messaging to poor people, or bots text messaging to poor people. Is your baby breathing fast? If so, go to the doctor immediately. The hospital is dirty. The last time I brought my child there, he died. Is your baby having diarrhea? If so, go to the doctor immediately. One thing that was very obvious to me as I decided to go be a little bit more techie in my approach was that you would never develop something abroad that you would not use here, because that's called disparity and perpetuation of equity and colonization, right? So you wouldn't do something like this. So I thought to myself, well, what would we use here that we would use there, or should we use here that should be used there? And I thought, okay, whatever it is, it has to measure how the system is doing. For example, I know that medical care is a business, so we'd have to look at okay, how much money is being made per unit time, but break that down, where Where are the drugs that are making the money? Where are the drug stockouts? I know that had to be considered, right? It wasn't my emphasis, but I'd be dumb not to think about it. But then I cared about what was in the middle. Like what, again, the behavior is adhering to protocols. So I want to measure adherence to protocols. And I want to do that, and you see in the very top, as a total, but then I want to see every single diagnosis, right? Because you're a busy program manager, director. You're not going to just like focus on pharyngitis. If people know how to do pharyngitis, you focus on the things that the system's not doing well. And of course, if there's any deaths, that should be highlighted immediately. You know, what kind of health system do we have if someone dies and you're like, oh, sorry, I was eating a hot dog in the mall? I mean, that would be the wrong type of intervention. So you would need to highlight any quote sentinel event while looking at the things that are a little bit more mundane. So I came up with this, and this is just a short, you learn when you are a CEO or a startup that you do everything. So I started just doing videos myself. And so this was one of our first promotional videos made for $200, $220.
The outpatient clinic where most people in the world receive their healthcare is decades behind other industries. One problem is that most medical documentation is still done by pen and paper. This leads to lengthy registration times, doctors spending more time with charts than with patients, and serious risks for miscommunication. Another problem is that doctors, nurses, and midwives don't get much help with decision making. With over 50,000 diagnoses and 4,000 medicines, it's hard for clinicians to figure out what to do in 10 minutes. Patients better hope that their doctors graduated at the top of their class, or that this year is a much better year than last. Walking Doctors was founded to tackle delays and mistakes in patient care anywhere. We focus on what is common to all medical practice, the medical record, making it electronic for instant referencing, building in disease checklists for faster, correct decision making, and displaying health facility outcomes for documented impact. The end result is complete, effective, and transparent care for the patient-provider experience out. This has system-wide effects, including 100% increase in protocol adherence across all diseases, and a growing cadre of happy customers committed to quality care improvement. With Walking Doctors, health staff finally have access to the tools that even superheroes require. Who will you save? We are Walking Doctors, quality care anywhere.
Come on, that video is worth at least $225, don't you think? So one point of this is that I worked outside. I had to create my own company because I wanted to do what I need to do. But in terms of NYU, I've learned so much, or I'm so grateful to the institution because they still allow you to be yourself, right? I am NYU visiting associate professor. That comes with a certain identity, but I also bring with me my identity. I bring an identity and contributions from my side, which people are very open to. And that will be the same thing for students. You will come with an identity and a body of experience that will be appreciated by the institution, and then combined. And so what I mean by that is I've really learned and been happy with a lot of the partnerships that I've developed. Like I write grants and I'm not that great with epidemiology and biostats. I need the departments to help me with these endeavors on the hand, and they need me a little bit for implementation, which I'm a little better at. Patricia will know because he was a recent graduate, and congratulations, Patricia, again, of the Stern Business School. But the Stern Business School has programs available to entrepreneurs that teach you how to do startups. They have contests. You can also take classes there. But I mean, this is something even that I participated, where they teach you things that I learned the hard way, like the triple threat of product development. Like, oh, I always tell my programmers, I want this, and this. And I ask my CTO, the chief technology officer, can we do this? And then his face will turn red and said, of course we can do it, but it will take time and money. And I'll say, but we don't have time. And then I'll say, well, then give me more money. You know, things like that. If I had just learned a little bit earlier on, would have saved a lot of money. Another thing is to do customer discovery. change our product left and right, blah, blah, blah. I think it's finally to an okay point. But if we had just done customer discovery, Patricia's probably laughing inside. Like, of course, you start with the customer and the who's going to buy your product. But I didn't. I came up with a thing that I thought would work. And that is not how you start. So fast forward, I still use system thinking. Now I'm flexing it to lessons that I've learned because I have to now teach these classes. Like, oh, my systems thinking was more logical framework. This is more system thinking. You have to assign like responsibility to certain things, but it's kind of the same idea. The point is that it all comes back to you, just like that interception case. The lessons that you learn and apply in one area or at one time will come back. So we're not huge, but I can't tell you how fulfilling it is to go to all these different places and you see nurses, registrars, doctors, pharmacists, pediatricians using the system that you designed. You don't always use it the way you wanted them to design, but it's certainly a start. This is an emergency room in northern Sumatra, very remote. And this is, I put this here because this was actually one of our first pilots when we first started in 2017. And the partners took great risks in trying to start something new, but you could see that there was great joy in partnering for change, partnering for good, partnering for a result that everyone could agree on would be good, and that would be that the welfare of ordinary people would continually and systematically and uplifted at scale.